World Sickle Cell Disease Patient Week has been going on for a few days now, and I thought we should pause before the next sessions and recap. In other words, recapitulate some of the things that we have said. The first of which was that I dare to start World Sickle Cell Disease Patient Week primarily because I was born into a home with 3 sickle cell disease patients as the 3 of the 11 children of my parents. So I knew about the disease before I went to school because my immediate elder brother had sickle cell disease and my immediate younger brother had sickle cell disease as well. And then when I went to medical school, I learned that what we used to call hemikom or in the African tribes was what the Europeans and Americans referred to as sickle cell disease. And then when I qualified at Westminster Hospital School of Medicine, and I went back home to Ghana and ran the largest sickle cell disease patient clinic in the world, I knew more about the explanations of the symptoms, in other words, the pains and the aches which the patients had. I knew also because I was invited to the World Health Organization special human genetics panel in Geneva. I learned that what people have been referring to loosely as sickle cell anemia, sickle cell disease, had genetic definitions which I adhere to. Unfortunately, going on Facebook, people use the terms just as they wish. Some say, I have sickle cell. You don't know what they mean by I have sickle cell. Others say, I have sickle cell anemia disease. Sickle cell anemia is sickle cell disease by definition. And by definition, it's sickle cell disease where both of the parents of the patient donate sickle cell gene to the person. So the person who has sickle cell from father and sickle cell from mother is the only person in the world who should be called sickle cell anemia patient. That is the World Health Organization definition. Of course, they are also known as having sickle cell disease. But when you mention sickle cell disease, you must add the phenotype. You must add S. In other words, S from father, S from mother. Why? Because sickle cell anemia, SS, is not the only sickle cell disease phenotype in the world. In fact, I have listed more than 15 sickle cell diseases from inherited from both of the parents, not only one, if you inherit sickle cell gene from just one parent and a normal gene from the other parent, you do not have sickle cell disease. You have sickle cell trait. And to confuse sickle cell trait with sickle cell disease is the greatest mistake made in the world about hemoglobin abnormalities, not only among the patients and the visitors to Facebook, but among doctors. Among doctors, as I said in one of my recent posts on the World Sickle Cell Disease Patient Week, even specialists confuse the term. I referred in writing a sickle cell anemia lady to a world authority in surgery on the gallbladder. And I wrote a note and said, "Dear so and so, please remove the gallstones from this lady with sickle cell anemia." I saw him half an hour after he saw the patient, and then he called on to me, "Hey, Felix, thank you very much for sending me that delightful sickle cell trait patient." And I said, "I did not send you a sickle cell trait patient. I sent you a sickle cell anemia patient." And then he said, "Oh, what's the difference?" Now, this is what I'm talking about. If even specialists do not know the difference between sickle cell trait, one normal gene from a parent, and one abnormal gene from the other parent, sickle cell trait, if they don't know the difference between that and sickle cell disease, one abnormal hemoglobin gene from one parent and another abnormal hemoglobin gene from the other parent. You must have two abnormal hemoglobin genes to have sickle cell trait if one of the abnormal genes is the sickle cell gene. Now, because of the so many abnormal hemoglobins, which if inherited together with normal hemoglobin, you get a trait. You get somebody who does not have any problem at all. I coined it, and that really is the only thing I have coined to help lay people understand the inheritance of this. Everybody in the world, whether you're black or white or yellow or Eskimo, Indian, Arab, Hebrew, everybody in the world has two genes, in other words, has two codes for forming hemoglobin, the red substance in blood. It is not only black people who have abnormal hemoglobins. Abnormal hemoglobins are found all over the world, but it just happens that Africans have more of the abnormal hemoglobin S, the sickle cell one, than most populations. But there is an area in Greece around a place where there was a lake called Lake Kopais, Kopais, where the sickle cell gene incidence was higher than anywhere else in West Africa. So it is not only black people who are said to have sickle cell trait, normal, abnormal, or sickle cell disease, abnormal, abnormal. So when I say norm ache for hemoglobin abnormality, I'm not only referring to black people, I'm referring to people in the world. In fact, I said in one of my blogs that I was asked by Professor Malcolm Milne at Westminster Hospital, Westminster School of Medicine Teaching Hospital, when I was a postgraduate. I was asked to examine a lady, a white lady, with a scar on the shoulder in front of a team of doctors and students and nurses. And knowing that Professor Milne, he asked me to examine this lady in front of everybody. I came to the diagnosis, seeing the scar on the shoulder and the scar in the upper abdomen. I came and looking at the fingernails, which were white, and the eyes, which were yellow, and asking where she was born. And she said, Greece. I astounded the group of clinicians standing around there by saying, this lady has a problem with hemoglobin formation. I think she has sickle cell beta thalassemia disease. In other words, beta thalassemia gene from one parent, which is abnormal quantity hemoglobin, not abnormal quality hemoglobin as a sickle cell gene. Beta thalassemia is abnormal production, abnormally low production of normal hemoglobin. So that is an abnormal gene. And sickle cell hemoglobin is not an abnormally low quantity of production of normal hemoglobin, but it is a normally sufficient production of an abnormal hemoglobin. The hemoglobin itself is abnormal, but both of them together cause a disease. So I said to Professor Milne and the group there, this lady has sickle cell beta thalassemia disease. The scar on the shoulder is because of necrosis of the bone there, which also occurs in the hip, and they have pain in the hip, and the abnormality formed in the shoulder. The scar on the abdomen is because they operated on the abdomen to remove the gallstones. So very important to have the definitions right. Nobody should just get up and say, I have sickle cell. You must qualify it and say, I have sickle cell anemia, which means I have S from father and S from mother, or I have sickle cell disease, which could also mean I have S from father and S from mother, but it also means I have S from a parent and an abnormal hemoglobin from the other parent. And the other abnormal hemoglobins that can cause disease with sickle cell gene, the other abnormal hemoglobins could be hemoglobin C, which is an abnormal hemoglobin. If you look at the cell with hemoglobin C only in the cell, you can find crystals, which should not be there, crystals of this abnormal hemoglobin. So when you have S from mother and C from father, as I had, my father gave the C to, I don't have SC, but I had 3 siblings, a brother older than me, a brother younger than me, and a sister younger than me. 3 of 11 children born had the S from mother and C from father, and they had SC disease, sickle cell hemoglobin C disease. And I mentioned in the last lecture that we should not write sickle cell trait with abbreviation, saying sickle cell trait, SCT, calling it sickle cell trait. That is wrong, because S in sickle cell trait stands for sickle, and the C in sickle cell trait stands for cell, and the T stands for trait. But if you write SCT, many people will think this is sickle cell hemoglobin Jing plus hemoglobin C Jing, and the two together can be called a trait. This is ignorance, but it's a dangerous one, because you see somebody who has sickle cell disease and you call sickle cell trait, you will ignore her symptoms, his symptoms, and something serious may happen. Sickle cell hemoglobin is given the designation S, and normal hemoglobin is given the designation A. So sickle cell trait is AS, with the S, when you measure, never more than 39.5% in the best laboratories in the world. No sickle cell trait man or woman has hemoglobin S 50%. If you get a laboratory that gives you a report, sickle cell trait A equals 50%, S equals 50%, they have not measured the amount of S. This is very important, and I'll talk about it afterwards because of insurance fraud. There are some insurance companies that will load the premium of very healthy patients who are sickle cell trait, AS, like my mother, very healthy, had 11 children, who can load the premium 150% or even 200%, because they say, sickle cell trait is very dangerous. Oh, sickle cell trait is very, very dangerous. Now, this is not right. Those who want to learn more about this could go to my website, where I have mentioned published reports which were wrong, and some of which had the authors apologize for their fault. Go to www.sicklecell, as one word, SICKLECELL.MD, www.sicklecell.md. You'll get all the information about the false publications, and about the corrections, and about the confessions of the scientists who published the wrong information. The main reason, really, why I started the World Sickle Cell Disease Patient Week was to point out that the general impression that sickle cell disease is a condition which does not allow the patients to live beyond the age of 25 or 30 is wrong. So I presented a gentleman, a professional pharmacist, whom I interviewed and whom I diagnosed when he was aged 7. at the Korle Bu Teaching Hospital as SS, examining the father with sickle cell trait, norm ache, I would say, AS, and the mother sickle cell trait, norm ache, AS, who passed on the S from both of them to Ebenezer, and he became SS. I presented him. He's now 60 years of age. I presented him to show that somebody can be SS and can pass exams and can be a professional using the brains, the genes that the same parents gave him. So Ebenezer became a professional pharmacist, and he worked in a London teaching hospital as a pharmacist. And Ebenezer has not been put on 6 weekly blood transfusion, as some experts say should happen, in order to bring hemoglobin up to 11 grams. No. He runs hemoglobin levels less than 9, less than 8.5, without regular transfusion. Ebenezer also has never had hydroxyurea, which is now recommended everywhere, on radio, television, textbooks, that is the answer for sickle cell disease. Ebenezer rejects it. Why? He told us on the program that as a pharmacist, he's been asked to wear gloves before he handles the drug which he dispenses to patients. Why? Because he said, you heard him say, that he was told that hydroxyurea is a carcinogen. It can produce tumors. And he says this is on the label, on the bottle. So he says if he, as a pharmacist, is asked to wear gloves to dispense hydroxyurea, why should he accept the recommendation of experts that he, with sickle cell anemia and a low hemoglobin, take this drug because it increases the amount of fetal hemoglobin, which is a very good hemoglobin, fetal hemoglobin, and thereby reduces the amount of sickle hemoglobin in the cell. Why should he take it? But the point which I have made several times is that if you get a recommendation based on the cell, the red cell, without looking at what that recommendation does to the whole of the body, you are in trouble. Why? Because some chemicals can stop the cell sickling at all under any circumstances. But those chemicals, for example, carbon monoxide, would kill you. So you may have a patient who has cells which refuse to sickle because carbon monoxide has been flushed into the system. But that patient would be dead because of the effect of the carbon monoxide. Now, our kidneys, human kidneys, function by removing urea from the body. That is why when you urinate, the urine smells of urea. Urea in the body must be removed, must be removed. But hydroxyurea is given to load the system with this urea. Now, I do not want to pitch one expert against another expert. So what do? I ask my patients who have achieved, and I call them achievers, to give their opinion about this hydroxyurea, which the whole world is saying is the answer to sickle cell disease. And here is Ebenezer, a pharmacist, who does not take it. In fact, Ebenezer was at the first international conference on the achievements of sickle cell disease patients that I organized at the Royal Society of Medicine in London in 1993, 24 years ago, when he spoke. But at the same conference was the professor, the American professor, who introduced hydroxyurea on the basis that it reduces the amount of sickle hemoglobin in the cell. He was there at the conference. A year after this conference, hydroxyurea was proclaimed as beneficial to sickle cell disease patients. Well, Ebenezer is alive today, but I want any of the listeners of what I'm saying now to show me a single person who has been on hydroxyurea since its introduction in 1994. Show me a single person who has been on it regularly, who is still alive. Indeed, one very bright achiever who was at the conference in 1993 and came to our conference in 1995 in Ghana. A doctor who was top of his class in secondary school and in university, showing that he also inherited brains genes of genius from his sickle cell trait parents, from whom he had the S from father, S from mother. But he also had brains from father and brains from mother, which enabled him to achieve. He was at the conference, and he was invited by the British Medical Journal, he and another top hematologist, to write an editorial about hydroxyurea. Those interested can see the details of what I'm saying by just Googling his name with hydroxyurea and read. His initials are A. O. So just Google hydroxyurea in sickle cell disease and look for the initials A and O, and you will see this editorial which I'm talking about, in which the doctor said, and I quote, "Patients have been voting with their feet," unquote. Patients have been voting with their feet, unquote. So it is not the doctors who know best about hydroxyurea whose word we should take. It is the patients who have been voting with their feet. Why have they been voting with their feet? Why have they not been taking it? And this particular doctor, A.O., who was a consultant, who was a specialist, who was a member of the Royal College of Physicians, and who was a member of the Royal College of Pathologists, UK. Brilliant man. He stopped taking it. He was offered it on the basis of the effect on the red cell, but he himself stopped taking it. Unfortunately, he died last year. And had not attained the age of 55. Ebenezer, who was at the same conference in London, and who is a pharmacist, and who refused to take hydroxyurea, is alive today. You saw him speak. So, what advice do I have to anybody who is confused about all this? My advice is simple. Look for an achiever. Look for sickle cell disease achievers who attain the age of 60, who attain the age of 70, and who attained the age of 84. One of them died at 84. Elegant lady died at the age of 84 last year. SC, sickle cell hemoglobin C disease patient. And ask them how they have been able to achieve so much without regular transfusion, without hydroxyurea, and learn from them. Please learn from them. And in the coming lectures, I shall mention something else, which textbooks on sickle cell disease do not mention, but which textbooks like mine on the sickle cell disease patient mentions, and it is this: abnormal hemoglobins are not the only things inherited from our parents, and some African parents, and some parents in Greece and the Mediterranean areas and in Israel. There is something called G6PD deficiency. G6PD stands for glucose 6-phosphate dehydrogenase deficiency. I'm going to say that again. Glucose 6-phosphate dehydrogenase deficiency. And on my website, www.sicklecell.md, I have shown 20 ways in which people with G6PD deficiency present in hospital. I'll be sitting at the Korle Bu Teaching Hospital outpatients, and a young man would come in panting, "Oh, doctor, I've just passed urine like Coca-Cola. Ow, 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 I'm dying. Now, the patient comes in, and the first question I ask is, what tablets have you been taking? I avoid the word drugs because there are some patients who are extremely sensitive. When you ask them, what drugs are you taking? They think you are talking about cocaine or hash. So I just ask, what medication are you taking? And the patient would just say, "Oh, doctor, I was diagnosed with typhoid fever a week ago, and I was given chloramphenicol. And 3 days after taking that chloramphenicol, I began passing water like Coca-Cola? Now, that's the answer. There are some perfectly good drugs like chloramphenicol, nitrofurantoin, fancida, perfectly good drugs and some antimalarial for the generality of people. But those who have inherited G6PD deficiency must not be given those drugs at all because they destroy the red cells and the pigment in the red cell flows out of the urine as dark as Coca-Cola, and the patient is anemic and very ill. And we have the professor in Ghana, Professor Samuel Kwadwo Owusu, who is the first, he was the first in the world to show that G6PD deficiency was not only problematic with red cells, but as this enzyme is found in almost all the cells of the body, it affects the brain. It could send you into coma if you have a deficiency and you took a drug which you shouldn't take, and so on. Now, all this has been referenced where he publishes articles. I have mentioned his name and the articles on the website. Now, why am I saying all this? Answer. I'm saying all this because if you talk only about sickle cell disease, you don't talk about G6PD deficiency. But if you talk about the sickle cell disease patient, then you talk about somebody with abnormal hemoglobins and who may also have G6PD deficiency, because 1 in 5 of all West African males have G6PD deficiency, and they don't know about it because there had not been an opportunity to take a drug like chloramphenicol or a peculiar anti-malaria tablet. And they could live and die without knowing that they had G6PD deficiency, because that deficiency is detrimental only when you take certain medication or when you eat certain beans like broad beans. All this is listed in www.sicklecell.md. So people who come around with medication for sickle cell, and they don't even talk about the fact that 1 in 5 of the sickle cell disease patients that you're treating who may have a urinary tract infection, which may deserve nitrofurantoin or furadantine to cure the urinary infection, may send them into coma, may send them into further anemia because of the destruction of the red cells. So you look at the patient really, and not only at the disease. This really is why we should look at the whole person. Now, my patients are taught to help me look after them. And a patient is given full marks when she comes to me or he comes to me and says, I have G6PD deficiency. And then I will say, oh, I forgot all about that. Say, yes, I have G6PD deficiency. So before I put my pen on paper to prescribe the drug for her or him, I make sure that I don't give a drug, a very good drug like ciprofloxacin, very good antibiotic, or Septrin, very good antibiotic, antimicrobial. You don't give it to them because it may do them more harm. This may be one of the reasons why siblings in the same home, two brothers, both with SS, sickle cell anemia, one does less well than the other. One is always being admitted. The other is not being admitted so often. When they are both SS, sickle cell disease SS. Why? Listen very carefully. G6PD deficiency is inherited in a peculiar way. And this is how it is inherited. A man with G6PD deficiency never gives the gene for G6PD deficiency to his sons. He gives them to all his daughters, but in half strength. What do I mean? In other words, if a man with G6PD deficiency who will have problems on taking 6 tablets of sulfonamides for his gonorrhea, if you like. If he has 4 daughters, all the daughters